All right, thank you very much. Okay, you can hear me in the back? Good, and folks that are attending remotely can hear me too. I think this is on. Welcome to the afternoon session. This is too nice of a day to spend inside, but hopefully this is going to be worth your while. You might be wondering why two people from Cornell are talking about insulin. I tell you, we do other things there as well, but at least it's the Joe and I up in different sessions, so we can't fight too much with each other. But this afternoon, what I wanted to do is talk about the role of insulin and glucagon. So I specified it to these two in health and disease of the transition cow. And this is a big title. I can't answer all the questions about health and disease in transition cows as regards to these two hormones, but I put together a few different ideas and some work that we have done on prepartum overfeeding in transition dairy cows and how to respond postpartum. So with that being said, I just give you a brief introduction. I think you've heard this morning already about the particular situation of the transition cow. We think of them as metabolic athletes. That's why I have this picture in here, although they're not super fast most of the time. But as far as their caloric needs and increase in their metabolism goes from pre to postpartum, they really do a tremendous amount of change in their metabolic activity. So when we look just at the energy requirements, and I'm not listing protein, I'm not listing calcium here, just looking at the energy requirements in the week prepartum to the week postpartum, there's more than a 2.5 to 3 times increase in a very, very short period of time that these animals require. At the same time, those of you who are working with cows, and I've been told not everybody here works with cows, so I hope I'm going to give you enough background to understand what I'm talking about. For those of us working with cows, the caveat in the situation is, yes, we have this increased energy need, but at the same time, the cows stop eating the same way that they were prepartum. And some of this drop is preventable, but not 100%. So most cows show a drop in this primary intake, and most of the time it's about 30% of their previous intake. Postpartum, they only slowly incline in their intake, and so they lag behind with their intake to the energy needs, protein needs, mineral needs, to what they require, and this creates this transition period conundrum of negative energy balance, negative protein balance, and risk for hypocalcemia, for example. So for those of you not working with cows, when I say dry cow, it's the cow not currently lactating. Strange word, but that's how we call them. And then obviously lactation starts with the day of calving. So when we speak about health and disease in the transition cow, we often look at these markers, BHBA and NEFA. BHBA is beta-hydroxybutyrate. It's one of the ketone bodies, and NEFA are fatty acids that we measure in the plasma or serum that are indicative of lipolysis from the adipose tissue. Why are we interested in these? They are markers that tell us which cows are at increased risk of developing downstream diseases. When I say markers, it means there's not necessarily a causative factor here going on with causing these diseases, but they're associated epidemiologically. They're associated with diseases such as increased risk for metritis, mastitis, decreased reproductive function, and decreased milk yield. And when these are increased, we also have an increased risk of removing the cows from the herd, either alive or dead. Some cows are very successful in managing the transition period despite having high concentrations of BHB and NEFA. I just wanted to put this out there. But in general, cows that have these increased concentrations are at higher risk for diseases. So what makes some cows have these higher concentrations and others not? We kind of look back into the prepartum period for clues to what might be happening there. And the reason why we do this is that this happens really soon after calving. Okay, so there's not a lot of chance to have other factors come in that are having a time lag. So we really are interested in what's happening in that prepartum period right around calving that's maybe explaining these differences in the risks of these cows to develop these high concentrations of these markers and then downstream diseases. So for a while, and some of us still discuss this, and you've heard about this before in the morning sessions, we considered insulin resistance as one of the risk factors. So what if something happens that makes these cows insulin resistant and therefore drives increased lipolysis, decreased response to insulin, and that gets them into the situation of fatty liver, and that gets them in the situation of increased ketogenesis. I spent my PhD looking into this topic, and I came out of it thinking that this is probably not what I would want to spend the rest of my career working with. So I'll tell you that now, but I'll give you a little bit more of an idea of why I came to this conclusion. So insulin. We'll start with looking at insulin. All of us who study metabolic disease, especially if we work at Cornell, have to read this seminal paper from Alan Bell in 1995. You may have read this before as well, in which he says, early lactation is characterized by a moderate degree of insulin resistance. He bases this statement on 3 studies that have been published between 1989 and 1990. They compared here sheep or goat, or in these models, because they're, as we heard this morning from Joe, a little bit easier to work with and cheaper to work with, using hyperinsulinemic euglycemic clamp tests to figure out the story about insulin resistance. If you feel like you want to do some historic literature search, I recommend reading these publications. These are the 3 that he's referring to in his work. And if you actually go into the publications, the story of these animals being insulin resistant postpartum isn't quite as clear as the statement would suggest. So even the authors of these publications said, well, we saw a decrease in sensitivity, but only at very high concentrations of insulin, for example, which are, I would argue, unphysiological in the postpartum period. In other models, they used hind limb clamps, seeing the uptake of glucose into the muscle, for example. And they also said that these are decreased, but only at very high concentrations of insulin could they see the difference. So what is insulin resistance? And I'll go over this briefly because we've heard about it this morning. We normally have a response to insulin that has a certain biological outcome. That's normal or physiological. If we see this response happening, but we have to have increased concentrations of insulin to make it happen, that is called decreased insulin sensitivity. If we have a decreased biological response, say you can't decrease the concentration of glucose to the same degree in animals that are then responding in this way, that would be a decreased insulin responsiveness. So you do not get the maximal biological response. For decreased insulin sensitivity, that means you need a higher dose to reach the same response. And for the decreased insulin responsiveness, it means the maximal response cannot be reached. So insulin resistance is a decreased sensitivity, a decreased responsiveness, or a combination of both. And that's already where it gets a little bit complicated. Moreover, we can have a whole body insulin resistance, or we can have tissue-specific insulin resistance. And I think the question this morning was, is the mammary gland maybe responding differently than other tissues in the body? Classically, we express insulin resistance as an insulin-mediated glucose disposal. Okay, so that's usually what when there's an S missing disposal, that we use to measure insulin resistance. So back to the question that I asked in the beginning. What could be happening that is explaining the prepartum effects on this postpartum risk for negative health outcomes? One of the observed things that we see from epidemiologic studies and lots of feeding studies is that overfeeding of energy in the prepartum period is associated with postpartum outcomes such as higher risk for ketosis, excessive lipolysis, a rapid loss of BCS, poor reproductive function, risk for disease in general, fatty liver, and even ovarian cysts. So again, the question here is there some mediation of these effects via the route of insulin resistance? The way we address this is we fed dry cows either a controlled energy diet, which would be approximately 100% of their energy requirements throughout that period, or we fed them a step-up diet, which is typically done in the dairy world, where they have a different diet in the far-off period, further away from calving, but a little bit more energy close up to calving. And then we compared this with a group that got 50% more energy than they actually needed by calculation. Each of these groups had about 28 animals. For those of you not working with cows, this is what cow feed looks like. We chop everything up and mix it together and present it to the animal in a total mixed ration, TMR. To change the energy density of these diets, what we did is we altered the ratio of corn silage, which is high in starch and energy, to straw, which is like eating salad for lunch, which I just did. And it's a lot of volume and not very much energy in there. With these alterations, we could achieve these percentages of energy that I just pointed out in the previous slide. So for those of you interested in how we did this, this is the way we do it. We let them eat as much of these diets as they wanted, but we knew that the energy densities were different, and so therefore we could control their intake in energy. Of note, we did not restrict them in protein. Okay, all these diets were equalized in what we would expect as their metabolizable protein needs, and I think that's important in understanding the outcomes of the study. You would probably ask me this if I didn't show it to you, what were the effects on milk production? Because that's extremely important when we talk about energy balance, right? The milk production is what draws a lot of the energy out of the system. And so I wanted to show you that these groups did not give different amounts of milk postpartum. Normal increase in milk yield until you reach kind of this plateau around 48, 49 kilograms. So a pretty high producing herd. So let's look at these markers that I introduced you to. BHBA and NEFA. On the left here, you see BHBA millimole per liter at 4 different time points in the transition period, 2 times in the dry period and 2 times in the postpartum period. And then on the right, NEFA in millimole per liter as well. Remember, NEFA comes from lipolysis, so release of fatty acids from adipose tissue stores. BHB has different origins, but some of it will come from an increased influx of NEFA into the liver and overwhelming of the Krebs cycle, and therefore a production of ketone bodies. And that's the main driver of BHB production in the postpartum period. As you can see here, we did in fact produce the metabolic picture in these cows' overfed energy that we have been hearing about prior to this study. In fact, if they were overfed energy prepartum, they had higher BHB concentrations and higher NEFA concentrations in the postpartum period. And the difference in BHB was even still there at 3 weeks postpartum. What about glucose and insulin? Interestingly, when you overfeed cows, they have higher glucose concentrations. And we're not the first ones to find this, but you can actually drive the glucose concentrations in blood up by overfeeding them energy in the dry period. However, after calving, these same cows then had lower concentrations of glucose. And you can see this here. Ooh, I should not do this. Okay, I guess I can't point. That's a new one. Do not touch the laptop, I guess. Okay. I just want to give you a mental break here for a second. So in the postpartum period, this picture reversed with these cows that were previously overfed energy having lower concentrations of circulating glucose and lower concentrations of circulating insulin. One thing I wanted to point out here, I just take the opportunity to do this, is that often we describe these cows that have ketosis postpartum as potentially being diabetic and hyperglycemic. In none of the work that I have been looking at and that I have produced myself, have I seen that cows with ketosis postpartum are hyperglycemic. They are hypoglycemic, if anything. Okay, I just wanted to point this out here. There's still a lot of throwing around type 1 and type 2 diabetes in literature when we talk about ketosis, and I think that's probably an outdated concept that we should let go of. But back to the concentrations I showed you. Is overfeeding causing insulin resistance? Well, from what I've shown you so far, the circulating concentrations of BHB, NEFA, glucose, and insulin changed, but the way that they behave would not be suggestive of insulin resistance, right? We do not see an increased glucose and increased insulin in the cows postpartum. What about the whole body tissue and tissue insulin response to glucose, though? To study that, we did 336 intravenous glucose tolerance tests. So we subjected every animal in the study to 4 intravenous glucose tolerance tests at the same time points I previously pointed out. Those of you not familiar with intravenous glucose tolerance tests will see that you put a jugular catheter in these cows, like seen here. You rapidly infuse them with a bolus of glucose, in this case, 1/4 gram per kilogram body weight of 50% glucose IV. And we did this to all animals in the 3 groups at 4 time points in the transition period. And then we serially sampled these animals and looked at the glucose disposal at the insulin response to this glucose challenge, and at the inhibition of lipolysis. Because remember, we wanted to know, is lipolysis maybe differently inhibited in the postpartum period in these overfed animals? What you look at to compare these outcomes are different curve parameters, such as the maximum response, the time to maximum in minutes, time to half maximum, and the clearance rate. And also you can describe the area under the curve, which sometimes is a better way of presenting these data to show. Okay, just a reminder, insulin resistance, we have this decreased responsiveness if we don't get the maximal biological response, or we need a higher dose of something to elicit the maximal biological response. So say we have the same glucose disposal, but we have a higher concentration of insulin, we would interpret that as decreased insulin sensitivity. Okay. Let's look at glucose clearance first. And I have put these in panels so you have a chance to compare the prepartum and postpartum responses of these cows. So you have 28 days prepartum on the top left, 10 days prepartum on the top right, and then the 2 postpartum time points on the bottom. What I would draw your attention to is that glucose gets cleared relatively rapidly, usually it goes down to baseline by about 90 minutes, that there was no difference between the 3 different groups, and that the glucose concentrations did not reach the same maximum postpartum as they did prepartum. And we know this needs to be true because we have immediate uptake of some of the glucose into the mammary gland as we infuse it into these cows. So you have to be really careful to compare prepartum to postpartum responses in cows when you do any of these challenges, because there is a different clearance of not only glucose, but also insulin. And we know from all of the old work I was introducing that with the same insulin infusion rates, they could not produce the same insulin concentration in blood when they infused it postpartum. So we know that there's a higher clearance of insulin from postpartum animals. As I said here, they look visually not different. And when we looked at them statistically and with all of the different calculations I introduced, there was in fact no difference between these 3 different groups. This is the insulin response. And so it makes sense that you infuse a large amount of glucose into the bloodstream, that you have this insulin response that happens soon after. Again, you see the 4 different time points, and I draw your attention again to the pretty large difference in responses between the prepartum animals and the postpartum animals. I hope you can appreciate that you have about 200 units per milliliter in the 28-day prepartum animals, but then in the postpartum animals, we barely get above 50. Okay, so with the same amount of glucose, you cannot produce the same amount of insulin response. However, when comparing the 3 different groups amongst each other, for each time point, there were no differences in the indicators of insulin sensitivity and insulin responsiveness. What about NEFA suppression? That's really a key point that we consider postpartum, right? Do these animals have high NEFA and therefore high BHB because they just cannot stop this lipolysis from the adipose tissue? It turns out that when you express this as % from baseline, they're absolutely equal. There's no difference between the 3 different groups. The magnitude of change postpartum was even greater, okay, because we had higher baseline concentrations, so the magnitude of dropping was greater. But so that's why I put them here as a % change from baseline, so we can compare them a little bit better. So there was no change in the absolute or relative reduction of NEFA concentrations and in the time to maximal suppression between the 3 different groups. So conclusions for this part about insulin. Insulin resistance, in our eyes, did not explain the postpartum metabolic outcomes of prepartum overfeeding. Baseline glucose and insulin concentrations are lower postpartum in cows that were overfed energy prepartum. So the question that we're raising here is there potentially a difference in hepatic glucose production? And then one question that I get asked, or that people raise, is it actually good or bad to have low insulin concentrations postpartum? The question comes up sometimes because cows that give more milk have lower insulin concentrations. And I picked some work from some previous colleagues at Cornell to show this in an observational study where they just looked at the milk production in cows that they classified by the median of their insulin concentrations at 10 days in milk into high insulin cows and low insulin cows. Okay, so just, they didn't do anything with them. It was an observational study. We're making associations. There's no causation here. However, they did see pretty dramatically, I think here, that the milk production of cows that have low circulating concentrations of insulin is higher throughout the observation period of 12 weeks. They also showed that the BCS loss of those cows in the low insulin concentration group is higher. So somewhere this energy must have been coming from, and they did see that they lost more body condition. And when we describe body condition loss, we usually cannot separate fat loss and muscle loss in the way that we judge this. But we do know that they had higher rates of lipolysis, as you can see here in the bottom right picture of the NEFA concentrations, that the cows with the low insulin concentrations do indeed have higher NEFA circulating in their blood. What they did not report, unfortunately, is the glucose concentrations in the blood of these animals during the observation time point. So some folks have taken this work and have proposed that we should make sure that cows have low insulin concentrations postpartum, because that would allow cows to give more milk. I just want to caution against this statement, because just because these things are correlated doesn't mean that if you drop the insulin, the cow will start making more milk. I actually think it's not happening that way. Not the authors of the study, I want to clarify that, but other folks have taken this and interpreted it this way. On the other hand, what if you had higher concentrations of insulin? Those of you working in reproduction, and I'm not, would probably agree that having higher circulating concentrations of insulin is beneficial to a return to cyclicity, to the quality of the eggs, and to the time to first ovulation, because insulin mediates the recoupling of the GH-IGF-1 axis that we've heard about earlier. Also, insulin is a potent antilipolytic agent, and it also reduces proteolysis. And so it can stop the body condition loss of these animals if it is present in sufficient concentrations. BCS loss, and I don't want to go into this in more detail, but BCS loss by itself has been associated with poor outcomes for health and reproduction and production in cows in the postpartum period. So our interest is in maintaining the body condition and minimizing the body condition loss in these animals. So I'm putting these two different stories to, against each other. Is it better to have low insulin concentrations because maybe we allow more milk production? Or is it better to have higher circulating insulin concentrations because that has better outcomes for reproduction and health? And I'm hopefully going to have a time in the end that we can discuss it, maybe even in light of the presentation of this morning. So glucagon is the other hormone I want to talk to you about today. I think glucagon unfortunately has received very little attention. It seems to be like the ugly stepbrother of insulin that nobody wants to spend time, dealing with. And glucagon is not actually that much harder to measure than insulin. They have, the same radioimmunoassays, so you're always measuring immunoreactive insulin and glucagon, and I should say that in these studies we always measured immunoreactive insulin and glucagon, but it's just kind of falling by the wayside sometimes when we talk about insulin. However, the pancreas makes these two because they're counteracting their effects, and they help each other out in balancing homeostasis in the glucose balance. So with that being said, those of you not super familiar with glucagon, it's excreted most strongly in response to low circulating glucose. It increases hepatic lipolysis and gluconeogenesis. It increases glycogenolysis, and it increases hepatic amino acid uptake, ureagenesis, and autophagy. So those of you studying autophagy on the cellular level, glucagon would be one way that this is increased on the cell level. So back to what I've shown you before, the panel, but now I made the panel wider and I just included glucagon in here as well. And you can see that in these same cows that have low circulating concentrations of glucose and low circulating concentrations of insulin, there's also an increase in glucagon. So we have sensing of the system that there is a deficit in glucose production going on here. When you look into the relationship between insulin and glucagon, you come across this molar insulin-glucagon ratio that some of you may have used before in their work. If you look at the indicators in human medicine or biology, an insulin to glucagon ratio of 3.8 is about normal for a regular diet of people who eat more than just salad. 1.8 is one where there's a low carb diet. So you're reducing the intake of carbohydrates, your insulin to glucagon ratio will drop. And then anything that's under 0.4 is considered starvation. Back to this picture I showed you, but now I put on the y-axis the insulin to glucagon ratio, same time points. It's not surprising because insulin and glucagon were both statistically significantly different, that the ratio also is different in these cows. When I apply those cutoffs from human biology, so 3.8 being a normal diet, we're about there in the prepartum period at 28 days prepartum. We are getting close to the borderline of low carb diet in that last prepartum time point. We're in starvation situation in the 4-day postpartum time point. And then we're climbing out of that slowly at the 21-day postpartum time point. Now, I'm the first to say we shouldn't take human biology and apply it to cows because it's really difficult sometimes to make that argument. But I do think that it fits with our observations that these cows are just in very severe negative energy balance and in need of nutrients. When we look at hyperkinemia, which is an increased unphysiological production of BHB or ketosis, we also see that these cows are making more glucagon. Okay, so it's different between cows that go through the transition without making increased concentrations of BHB from those that respond with hyperkinemia. So again, just wanting to bring this point home that glucagon is important in this relationship. And I think Dr. Brookmeyer has pointed out this morning that there is a relationship between ketogenesis and glucagon plays a role in the adaptation to metabolic balances in the postpartum cow. Looking at this slightly different, I'm just looking here at the insulin to glucagon ratio again in cows that were affected or not affected with hyperketonemia. And you can see that this insulin to glucagon ratio is lower in these animals that were experiencing hyperketonemia compared to those that did not come into this a situation of hyperketonemia in the postpartum time points, and that's any time between 1 and 21 days in milk or days after parturition. So conclusions. According to this work, and I showed you an abbreviated version of what we looked at, overfeeding prepartum does not, in our mind, cause insulin resistance. But maintaining insulin and preventing the glucagon rise, or altering the insulin-glucagon ratio to improve it, would stabilize glucose balance, or would be indicative of a stabilized glucose balance. How do we get there? For those of you working with dairy cows, we know that regulating dry matter intake and preventing the decrease in dry matter intake drops by either formulating diets, feeding consistency, controlling the loss of BCS is very important. In our work, we could show that controlling the energy that's fed prepartum is important. And we can also feed glucogenic diets in the postpartum period that help improve the glucose balance. What about glucogenic precursor supplementation? In some of the work where researchers have supplemented cows with propylene glycol in a blanket type of supplementation, for example, they could improve the insulin concentrations in these animals by adding more glucogenic precursors into their system. And then the question that I have, and I hope we can have a little bit of a discussion here, is can we prepare the liver for being more able to produce glucose, in other words, improving the hepatic gluconeogenesis capacity? Because after all of this work that we have done, we think that by overfeeding these cows prepartum, we're putting them in a situation where in the postpartum period, they're not making as much glucose or not as efficiently as their counterparts who were fed a controlled energy diet. With this, I want to acknowledge everybody who's helped here and the funding sources. And I hope, we have some time for questions.